Good day. This is the testimony for February 3rd, or rather the comments for the Ways and Means Health Subcommittee on bridging the health equity gaps for people with disabilities and chronic conditions. In this, I've provided written comments. I start off by stating that the major health problem for people with disabilities is qualifying for SSDI and then having adequate income. Having adequate money for shelter, food, and spending money, and luxuries such as toilet paper. The recent COLA has helped, but it is not enough. Having a COLA in mid-year is still better. It would have been better last mid-year too. Diet is the main thing for health, especially for the physically and the mentally disabled. So without good diet, things get worse. My roommate, because he was not a high earner, relies on SNAP and additional Medicaid with his Medicare. He's dual eligible. And with these benefits, we have the same standard of living, which isn't great. He's a vegetarian, so he actually thrives pretty well. I am not. My experience, including Medicaid for the first 2 years, then my health benefits had various copay levels. I used Kaiser for Medicaid, Medicare's Parts B and D, and now Medicare Part C. But it was all with Kaiser, so that was pretty seamless. The co-payments weren't. Mental health care was more fluid. On Medicaid, I had access to nurse practitioners, but not doctors. But I was able to do a psychiatric rehabilitation program, but my therapists were one kind of social worker. In Kaiser, they were a different kind. They had different degrees and licenses, and for the life of me, I couldn't tell you what the difference is. I'm sure there are experts who could. But now everything's with Kaiser, but I can't do a PRP. But I do have the freedom to change plans every year. Now, Eric, my housemate, we just mailed his and I helped him because of his literacy. We have to recertify every year, and if something goes wrong, then he gets all afraid, and he should be, because it's confusing to him. And even though I was an ombudsman with the city and a congressional staffer doing constituent service stuff, I was in Washington, so it was limited, but it was still stuff I had to do. We both have telehealth now, so that's good. Although I have to pay for the cable internet, he's gotten a free tablet, so he doesn't have to use this computer. And he could do a hotspot on his phone. But right now, there's no need if I'm doing wireless. So he buys me shrimp occasionally. Now returning to the main topic, for most of the disabled and underserved, especially undocumented workers who rely on emergency room care and have little access to specialists, all solutions require a dedicated and well-paid cadre of workers. That's where the gaps are. People need help navigating, and unless we go to some kind of single payer, which I'm going to get to in a second, the gaps are huge. And that's true for anybody, any kind of disease. Integrating care systems, which is great, isn't enough. You have to integrate social services too, so that if somebody starts with the city or the state or the county, their social work goes with them through the process. The PRP should, or we also have social workers through our housing provider, but it should all be seamless, and it's not, and that's why people fall through the cracks. Case management data systems are necessary too. We also have to have comprehensive sick leave, especially for poor people. with disabilities, without, with children. And some people used to consider having children a disability. It no longer is legally, but it's still treated as such. And I know. So people a lot of people can't go to the hospital, to doctors or university, and work for normal office hours, so they end up in emergency rooms at the dead of night with their sick kids. Probably still during the pandemic. Of course, emergency care is very expensive, not because of the inherent cost, but because of billing practices. Companies, especially for-profits, make the choice to charge off their equipment to people who don't use it. And that's crazy. As a former cost analyst with the Pentagon, I would have never and a former contract specialist with energy, I would never, ever, ever let that go on a contract, even a fixed price contract. They'd get a letter. So, it's that negotiation thing we talk about in Build Back Better. Of course, another major gap is undocumented workers. If they can't pay for care, the Medical Charities Fund will cover the cost, but they still have rounds of bill collection, and they can't get rid of it through bankruptcy. It just, they're between a rock and a hard place. If they get hurt, and undocumented workers get hurt, they do the jobs that, hurt your back. They get cut in food processing, get sliced into their hands, and, they don't get physical therapy. They don't, they are underserved. And that's what, if they have chronic illness, if their kid has asthma, they're in trouble. They do Primatene inhalers rather than albuterol, and it's just, no follow-up allergy appointments, any of that. Even if they have allergies, they sometimes have to work in the fields. It's just nasty. The whole point of healthcare reform was to eliminate gaps in coverage. Not including undocumented workers was an olive branch to Republicans who didn't vote for it. Sorry, my apologies to the minority, but you did, and it's, it's the majority in the Senate's problem too. As soon as there were no minority votes, they should have put it back. And anybody who was hurt by that, the senators from Nebraska and Arkansas, who insisted on a more conservative bent, didn't win re-election anyway. One of them didn't even run, so it didn't help them. So this should be a hint to those members who are not supporting Build Back Better. Ms. Lincoln and Mr. Casey, they catered to them, and then it went away, and we didn't get a public option because of it. Now that the pandemic has run its course, we have universal humidity. The current supply chain in food, however, is off because of the undocumented workers who have to work sick, or they're too sick to work. Let's learn this lesson and offer them essential coverage, or universal coverage, mandatory sick leave, and right to work. If you've got union coverage, the chronic problem goes away. The unions will make sure that their workers have good benefits, and chronic, disabled, the like. Next we'll cover comprehensive reform in part 2 of the video. I'm doing that because the remainder of these comments are identical to the Ways and Means comments made the day before. So I will link to those in the comments. You can keep up where this left off in both cases, because the comments are as applicable in each case. For those who are watching this who aren't on congressional staff or members, the usual caveats apply as far as helping fund our efforts. If somebody actually provides real good funds, I'll have to disclose that in the comments, or in the disclosure piece. So at least if you're part of if you're a client. I don't think donors have to disclose, but it'll affect my contact sheet information. But without further ado, I will go to part 2. Thank you much.